context, it's amazing that we're rapidly approaching the 100th year of discovery of insulin. And unfortunately, when we look at routes to normalize patients' blood sugar levels, not a lot has changed. Insulin injections still remains the mainstay treatment for the broad majority of patients with type 1 diabetes. There has been some advancements in the sense that we have these new artificial pancreases. These are insulin pumps, and they could also be glucagon pumps as well, tethered to a continuous glucose monitor. But when we look at the function of these artificial pancreases before and after implementation, I'll draw your attention to the gray shaded area. That's the normal physiological blood sugar range. And after implementation of these artificial pancreases, we can see an improvement in blood sugar control, but by no means in a physiological level. And an alternative approach to restore carbohydrate control to T1D patients is through transplantation, and really driven in large part by the Edmonton group, pioneered by Dr. Rajat and the Edmonton protocol. And in this application, you take a cadaveric donor, so a human pancreas, isolate the 2% of the pancreas that is responsible for endocrine function, and transplant this about a tablespoon or two back into the liver of the recipient, where they hopefully embolize, engraft, and function. And a caveat to this approach is that you need lifelong immunosuppression as of right now. But when we look at the impact on patient care and patient quality of life and glucose control, there's really nothing that even comes close to that. So we can see a patient's blood glucose profile before transplant, lots of highs, and more worrisome are these lows, and these can be life-threatening events. But after transplant, that's about 9 months post-transplant, we have completely normal, physiologically relevant glucose control. So essentially a functional cure. But the procedure's not perfect, and this is a bit of a busy slide, but we can see the amount of immunosuppression required to protect these islets of Langerhans. And in red, these are all the drugs that are currently being used to stop the immune reaction to these transplanted cells. So as a consequence, there's quite a bit of limitations to islet transplantation today. One of the main things is 70%, estimated 70% of the cells that we transplant are destroyed within hours to days, largely driven by the inflammatory reaction. And as a consequence, multiple organ donors are required to treat one patient. So it already puts a strain on a limited precious human donor supply. And then there's a requisite of lifelong systemic immunosuppression. So this really limits the amount of patients that are eligible for a transplant, and it also limits the function because these drugs are diabetogenic, and essentially what that means that these drugs induce diabetes. So it's a bit of a paradox. There's also a risk of infections, certain forms of cancers. There's organ toxicity, especially to the kidneys, and there's also insulin resistance. So while we need this immunosuppression, it really limits function and inclusion, patient inclusion. So what my lab is looking at is ways to enhance this beta cell engraftment and make it more inclusive to all type 1 diabetic patients. And the ways we do that, we have a multiple-pronged, multiple-pillar approach. So one of them is looking at extrahepatic sites, so looking at transplant environments outside of the liver, because we know there's limitations with that site. We look at localized immune modulation, so looking at getting away from the systemic broad spectrum immunosuppression, getting rid of all those red marks and drugs that we have to give to protect those islets. And we either do this with localized drug delivery or also immunoisolation, so physically separating the islets from the host. We're also interested in alternative cell sources, whether these be neonatal porcine islets in collaboration with Greg Corbett's group, or also stem cell derived insulin producing cells in collaboration with Christina Nostro in Toronto. And then what we're really excited about is this new pillar of looking at cell death and cell death inhibition, and how do islets really die? And a stellar master student that's really diving into this. So for the next 10 minutes or so, I'll dive into two of these projects. So when we look at how we can use encapsulation to improve islet function and survival, there's different approaches, either nanoparticles or scaffolds to help create a better environment. We've really been focusing on using drug-eluting biomaterials. So we have these little bubbles that we can transplant with islets and give drugs right to the site of transplant instead of the whole body. So one of the questions we ask, can co-transplantation of these drug-eluting microparticles attenuate islet allograft rejection? So can we reduce rejection by giving the drugs right to the cells? And this is in collaboration with Greg Corbett's group. And largely the champion and doing the lion's share of this work is Dr. Puru Kupan, a postdoc in the lab. So what we do, we make these microparticles, these micelles, which are basically like bubbles, and we impregnate different drugs. And our first indication was using dexamethasone, an anti-inflammatory. And this was recently published in the American Journal of Transplantation. And just briefly, we take a drug and a polymer, PLGA, we mix the two together, and using an organic solvent, we can emulsify the preparation, and we're left with these bubbles that have the drug impregnated within them. So essentially, they're about 50 microns in diameter. We can tune this depending on what size we want to target. And then the drug is encapsulated within these bubbles. And then over time, about a month, the bubbles will burst and release the immunosuppression right at the site of transplant instead of the whole body. So in our transplant models, to see if this is a functional way to treat patients in an islet transplantation, we essentially mix these bubbles with our islet preparation. And here we can see them in a tube. The islets are upstream and the micelles are downstream. And then in our preclinical models, we transplant them underneath the kidney capsule of diabetic mice. And these mice are made diabetic through a drug called streptozotocin. And then we're hopeful that the drug will be released and protect the grafts from rejection. So one of the first questions we ask, well, is it toxic? If we give these drugs right with the islets, is it going to hurt the islets? It might protect the immune system, but it might hurt the islets. So we did what we call a syngeneic transplant. So these are islets that won't be rejected. And when we put islets alone into the kidney capsule of diabetic mice, so anything above 11 is diabetic, we can see after transplant, they become normal, so normal physiological control until we remove the graft. We remove the kidney, the animal can survive on one kidney, no problem, and they go back to a diabetic state, confirming graft-dependent euglycemia. And we see the islets under the kidney capsule staining positive for the glucose regulatory hormones, insulin, and glucagon. Now, when we mix our microparticles, so these dex-eluting bubbles with our islets, we again can see we have a rapid restoration of insulin independence. These animals are completely normal now until we remove the grafts. So they go back to a diabetic state. And when we look underneath the kidney capsule, we can see these islets under the capsule, and these asterisks show the bubbles, the microparticles, the drug-eluting material. And we can see nice insulin and glucagon staining, and they respond well to a glucose challenge. So we were confident that this wasn't toxic, so we wanted to move into our allograft. So this is like the clinical scenario where we transplant cells from different species into the recipient. So the percent euglycemia curve really represents the amount of diabetes-free recipients post-transplant. And as a matter of context, the blue line is just our syngeneic. So after transplant, they all remain normal. But when we transplant these bulb C islets into diabetic C57s with these empty micelles, we have a rejection. All the animals will be normal for the first few days, but then they reject within about 2 weeks. So this is no immunosuppression, just empty micelles. When we use dexamethasone impregnating micelles, we delay rejection a little bit by about a week, but as a monotherapy, it doesn't seem to be enough. So in the lab, we use low dose CTLA-4. It's a systemic drug that we give for just 6 days. And with just 6 days of treatment with empty micelles, we have about 40% of the animals are normal. However, when we combine with the drug-eluting microparticles, this is the dexamethasone, we have about 80% of the animals are now protected from graft rejection up to 60 days post-transplant. So they're co-localized together. And how we prove this, that the co-localization is important, is we transplanted kidney islets on one kidney and the micelles on the other kidney. And we could see that in the green line, we didn't get that 80% in function and protection. We needed those cells and those microparticles together. So this is a bit of a busy slide, but when we look at our histology, the main take point about when we have these microparticles, we have higher insulin content within these grafts compared to the empty micelles, and we have more FOXP3 cells, and these are T regulatory cells. So these are cells that help keep back the immune system. So just a brief summary, I think we've been able to demonstrate that localized delivery of immunosuppression is possible through our PLGA me cells. And we're able to confirm that we can enhance allograft function, but when we combine it with low dose systemic immunosuppression, and that we have higher insulin positive and T regulatory cells when we use this approach. So we're quite excited in the future, and the future is actually now what we're doing. We're looking at multiple drug delivery platforms. So we're looking at multiple drugs in these me cells or a combination to target different immunology pathways. We're also optimizing our efficiency of encapsulation. So now we're about 70% efficient in encapsulating the drugs. And we're looking at more potent immunosuppressants. So not just anti-inflammatories, but some of the cyclosporin inhibitors. We're also looking at applying this underneath the skin through a JDRF grant, as well as stem cells through the stem cell network. And we're scaling it to large animals. Actually, currently, we're transplanting them on Tuesday. So we're pretty excited to see how that works out in the next few weeks. And then briefly, this is just hot off the press, some of the work that Salonia is doing, and this is through an ADF innovation grant, and we're looking at how do beta cells die. So classically, there's been two ways that we think that cells die. It's either through necrosis, and this is through trauma and it's not regulated, or apoptosis. This is a programmed form of cell death, and it provides avenues to have intervention. And even in clinical islet transplantation, we've used caspase inhibitors in the past with very limited success, but it's a mechanistic way that we can inhibit cell death. However, now we know that the regulated death isn't just to apoptosis. There's this regulated form of necrosis, and it's basically a cell death signal that is regulated and it becomes necrotic. And we're not sure if it's relevant in islets. It's just been discovered in kidney, but we're really curious to see if this regulated necrosis, so this programmable form of cell death, is important in islets and beta cells. And it's really the hallmark of it is this necrosome complex that we're trying to inhibit. And it's possible that if we inhibit this complex, we'll preserve islet function. And at the very least, the better we understand how islets die, it changes the calculus on how we can create interventions and different treatments for islet transplantation and even type 1 diabetes onset. So briefly, Salonia has been working in the lab to inhibit this necrosome. And our hypothesis is that if we can inhibit this, we'll improve islet survival and function, both in the culture dish, but also post-transplant. So how do we do this? We have some really cool drugs, these necrostatins, that we can really inhibit this necrosome formation and then block necroptosis. We hope it's relevant in beta cells. And we can initiate cell death by like a hydrogen peroxide insult. So our first experiment, one of the tools we use in the lab for viability is looking at how the cells consume oxygen, so basically how well they breathe. And we use immortalized beta cells. So when we try to inhibit, when we used H2O2 in the presence of our control and our necrostatin treated islets, we can see that in our control islets, we reduce the ability of these cells to consume oxygen. But when we inhibit necroptosis, we saw a slight increase. It was significant. It wasn't very drastic, nothing to write home about, but it at least gave us some proof of concept that this pathway of cell death is relevant in beta cells. And we thought, well, if it is relevant, maybe we're just switching cell death pathways from one to the other. We can block necroptosis with these compounds and we close that gate so that when we have cell death signals, it won't go down that route, but it will just go to apoptosis. And if we block apoptosis that we've done in the clinic with, say, ZVAD, maybe one of the reasons why it wasn't really successful is that we blocked that gate, but now we're shunting this regulated death down to necroptosis. So our next approach and our idea, our hypothesis, what if we block both? Will this have an impact on cell function, allowing those cell death signals to stay out of the cell and hopefully improve graft survival and function? So we found that inhibiting both necroptosis and apoptosis really improves beta cell function and survival. So this is looking at percent viability after 48 hours of hydrogen peroxide treatment. And we can see that this is quite deadly. Only about 20% of the cells in the control setting are functional. When we block apoptosis or necroptosis alone, now we're switching the gates back and forth, we really don't improve function. But when we combine our therapies that target both pathways, we can double the amount of cells that are now surviving and functional. So we're really excited that this is really just the start it lays the foundation of a whole bunch of experiments we can do to tease this out. But we think we now have a potential therapeutic target that we can treat. So just in brief summary here, we think that necroptosis is relevant in beta cells. The inhibition alone of either apoptosis or the necrosome as a monotherapy might not be enough. And we need that co-stimulatory or the co-blockade to enhance beta cell survival. So we have lots to do in the future. We're going to repeat this with human islets and neonatal pig islets. We're going to use some genetic techniques to knock down specific players in these cascades. And we're also using human islets, and we just started transplanting some of those from tatsua kin in the presence of these apoptosis and necrostat inhibitors. And then ideally, hopefully combine this with the project I just showed you with the microparticles and delivering these cell death inhibitors right to the islet graft as well. So sorry for going a little bit longer, but obviously I want to thank the ADF for all their support, as well as the members in my lab and Greg Corbett, who's been a great collaborator and mentor. So happy to take any questions you may have. And thanks again for your attention and time.